Hello.
Good evening, sir.
Good evening. Good evening. We'll start in 1 minute's time.
Good evening, sir.
Good evening. Good evening. Ida. Ida. കൊണ്ടുവന്നാളി അല്ല ക്ലാസ് വിളിക്കുന്നുണ്ട് മതി 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 കഥ വിളിക്കും മതിയില്ല അതെ Whether shall I start? Okay, we'll start. Okay, thank you. Is my screen seen? Hello?
Yes, sir.
Yes, sir. Yeah, okay. So we'll start with today we'll start with two short cases, two of which are given by Dr. Samia from Calcutta. Now, this is the first one. The story of an 18-year-old female. Just 1 minute. It's a problem. Okay. This 18-year-old non-immunocompromised female patient was previously diagnosed as disseminated tuberculosis. She had a family history of pulmonary tuberculosis in her younger brother. While on ATT, she developed ATT-induced hepatitis, for which it was discontinued by the family. She was admitted in a comatose state in the ICU and eventually mechanically ventilated, and tracheostomy was done. She had a long ICU stay complicated with sepsis and transient hypoxemia. A vague history of complete ophthalmoplegia along with proptosis of the right eye given by the patient's mother prior to admission. Now, this is not the important part of the story. She is a known case of tuberculosis. This is the video, this eye movement for which I have brought the case today. Look at the eye movement and what it is like.
बुखार हुआ था?
पहले बुखार और उल्टी हुआ था।
अच्छा, फिर क्या हुआ?
नर्सिंग होम में भर्ती करने के बाद बोल रहा है कि इसको ब्रेन टीबी है।
अच्छा
हुआ था।
अच्छा, वो अभी कैसा है?
वो ठीक है अभी, उसको चेस्ट में हुआ था।
अच्छा, और ऐसे आँख का जो ये हो रहा है, ये कब से हो रहा है?
उसी टाइम से था।
उसी जब से टीबी
हाँ, ये वाला आँख
ये जो आँख ऐसे ऐसे ऊपर नीचे जा रहा है, ये उसके पहले था जब आईसीयू में भर्ती हुआ था, तब ऐसे आँख ऐसे बाबू डान दिखे का डाइने देखो, बाएं देखो, ऊपर देखो, नीचे 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 देखो।
I think I'll make it broaden a little bit. Just 1 minute.
बुखार हुआ था?
पहले बुखार और उल्टी हुआ था।
अच्छा, वो अभी कैसा है?
वो ठीक है अभी, उसको चेस्ट में हुआ था।
अच्छा, और ऐसे आँख का जो ये हो रहा है, ये कब से हो रहा है?
उसी टाइम से था।
उसी जब से टीबी
हाँ ये वाला आंख ना
ये जो ऐसे ऐसे ऊपर नीचे जा रहा है, ये उसके पहले था जब आईसीयू में भर्ती हुआ था, तब ऐसे ऐसे बाबू डान दिखे था का दाहिने देखो, बाएं देखो,
She is unable to look either in a
ऊपर
direction.
देखो,
She is in altered sensorium stage.
नीचे
difficult to
नीचे
see.
नीचे देखो, नीचे देखो,
Pupils were dilated and not reacting to light.
खड़ हुआ था.
So this is the what is this ocular finding. Before that, I will tell the other findings which are relevant to our patient. The pupils were dilated, non-reacting. She was not responding to commands. However, sometimes she showed her tongue on command, but not her teeth. All details were lost with severe generalized wasting. The individual power testing could not be done since the patient was not responding to command. And this was the investigations done. Hemoglobin 8.9, TLC 18,500. Sodium, potassium, calcium for magnesium normal. Serum scrub type is IgM negative. CRP 48, procalcitonin 2.2. LFT showed resolving transaminitis with mild unconjugated hyperbilirubinemia. ANA panel, ANGA panel normal. And CSA report done previously had shown a protein of 1 gram, 480 milligram per deciliter, glucose of 28 milligram per deciliter, and lymphocytic pleocytosis. Neuroviral panel negative, autoimmune panel negative. Repeat CNS CBNAT positive for rifampicin resistant mycobacterial tuberculosis. So it's a known case of tuberculous meningitis. So these are the findings. What do you think about the eye movement abnormality?
Obsoclonus.
पहले बुखार और
Okay, ophthalmos. All are agree with the ophthalmos?
Oblique
Ocular bobbing
nystagmus
also
in
possible, sir.
Pardon?
acute
Ocular
hydrocephalus.
bobbing, sir.
Ocular bobbing. Somebody said ocular bobbing, somebody said ophthalmos.
So oblique nystagmus in acute hydrocephalus.
Very good. What do you call that?
So oblique nystagmus something.
That's not an oblique nystagmus. This is not a nystagmus. See, nystagmus, to have called nystagmus, there is a slow component and a fast component. All nystagmus should have a slow component. So here there is no slow component. Look at, it's a rapid one for movement. See,
अच्छा,
look at,
फिर
see
क्या
this
हुआ?
one.
नर्सिंग होम में भर्ती करने
Sir,
के
can
बाद
it
बोल
be
रहा है कि इसको
a
ब्रेन टीबी
ocular flutter?
अच्छा,
Yeah, ocular flutter. It just looks like an ocular flutter. By
Pseudobobbing.
ocular flutter is always horizontal.
Horizontal. The pseudobobbing.
Retectal bobbing.
Yeah. This is what kind of bobbing is called as?
Pseudobobbing.
Inverse ocular
Yeah.
bobbing, sir. Inverse ocular bobbing.
This is not ocular bobbing. Ocular movement, what? Sudden downward movement and slow upward drift. Okay. This mimics an ocular bobbing, but we will call this syndrome. I'll tell the story later on. Okay, this is the patient. So it's a case of tuberculous meningitis. Now let us see. This is the MRI of the patient. Flare shows hydrocephalus with edema, with the transemittable seepage of the CSF. This is the T2. After contrast, you can make out there is patchy enhancement of the leptomeninges in an irregular, what do you call, fashion, not a uniform enhancement. So all of the leptomeninges studded with exudates. I can show some of the exudates now. Here, this is the X1 exudate. Not a uniform enhancement, irregular, patchy, what do you call, that these are all sort of as if something is stuck to the meninges. Classical tuberculous exudate-like thing. So a procedure was done on this patient. Next is the video of the patient after the procedure. Look at the child now. That involuntary movement has disappeared. She's getting more conscious,
जीभ 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 दिखाओ
but not fully aware. Fully aware.
खोलो तो तू जीभ
She's
दिखा
still confused and disoriented.
मुंह दिखाओ जीभ दिखाओ
जीभ दिखा दो, जीभ दिखा दो, खोल तो मुंह, जीभ दिखाओ, जीभ दिखा।
এদিকে তাকা এদিকে
So the eye movement abnormality disappeared. So what is the eye movement abnormality? So what is the procedure?
V pattern convergence nystagmus.
No, it's not in
Obsoclonus and plasma exchange.
Not plus. Okay, okay. Let us see.
Post VP shunt, sir.
Pardon?
VP
shunt.
shunt.
Correct. That's perfectly correct. So VP shunt was done, and this movement disappeared. So what could be that movement?
So that Doll's nystagmus something, I forgot the name, sir, but it happens in acute hydrocephalus, sir.
Very, very good. Very good. That's correct. And the lesion is in the pretectal region. And that is where, remember, Dr. Sami has told that pupils are dilated and non-reacting. So what is that condition called as?
Pretectal pseudobobbing.
Very, very good. Perfect. That is the diagnosis. So this indicates that this is an Argyll-Robertson pupil or lightning dissociation. We are not looking for accommodation, but you can guess, but otherwise conscious dilated pupil mean the lesion has to be in the pretectal region, maybe in a lightning dissociation. So that both indicate a pretectal region, and this is what is called. This is also another case. Okay, similar case. This case I shown the INCON meeting. This 23-year-old patient had had a midbrain insult 5 years back. We do not know what the insult was. And this is the ocular. Look at the ocular movement. Here sometimes slow, sometimes again very fast. See that like this. It's going downward and inward. He is conscious otherwise. So this is in slow motion. This is second patient. It goes down and in, see, down and inward. And this is mimicking vertical saccadic intrusion like an obsoclonus, but only confined to the vertical direction. This is called pretectal pseudobobbing. This is usually seen in acute hydrocephalus, where the suprapineal recess impinged with the pretectal plate, causing this abnormality. Cytoplasm is pretectal region. Causes hydrocephalus, usually acute obstructive hydrocephalus. It can also be described in tectocerebellar dysgraphia. I do not know what this condition is. With an expanding posterior fossa system, the tectocerebellar dysgraphia. So what is this pretectal pseudobobbing? They are arrhythmic, repetitive, downward and inward eye movements at a rate ranging from 1 to 2 per second. Now, somebody can mimic an ocular bobbing, but what are the points differentiating ocular bobbing is that the correct thing is it's a V pattern. You can also have a rapid eye movement, slow upward deviation in pseudobobbing also, but it is not vertical. It's actually coming down and inward, and it's a faster rate, sometimes without an intersaccadic interval. And the lesion is pretectal, whereas the classical bobbing is in the pontine region. Now, this is just 2 sentences. Spontaneous, arrhythmic, rapid downward and inward eye movement, with downward movement being faster than the return. Pathophysiology believed to be related to the convergence retraction nystagmus and the V pattern esotropia that may occur with midbrain or thalamic lesion. This explanation given. So this procedure was VP shunt. Okay, any questions in that case? It's a short case.
So that video once more. Once more.
The first one or the first one, no? I'll show the first one, yeah.
बुखार हुआ था
पहले बुखार और उल्टी हुआ था।
अच्छा फिर क्या हुआ
नर्सिंग होम में भर्ती करने के बाद बोल रहा है कि इसको ब्रेन टीबी है।
अच्छा
If you look very carefully, they're going down and inward. Did you see that?
वो अभी कैसा है
वो ठीक है अभी। इसको चेस्ट में हुआ था।
अच्छा। और
Convergent
ऐसे आँख का जो
refraction
ये हो रहा है, ये कब से हो रहा है?
Not a
उसी
convergent
टाइम से
actually.
उसी जब से टीबी
हाँ, ये वाला आँख
In convergent retract nystagmus, the converge and goes inside and then slowly coming back. Here is only fast component is there. There's no slow component. To call a nystagmus, always there should be a slow component. Okay, the fast component is the corrective component. Here only abnormal saccades are only there without intersaccadic interval. Something mimicking a saccadic intrusion like an ophseoclonus.
So then how will you differentiate ocular bobbing from nystagmus? Sir?
Yeah, that's from nystagmus. See, in ocular bobbing and pseudo bobbing, I just not told you, it mimics ocular bobbing, but it always in ocular bobbing, that sudden downward, upward slow component. Sometimes in pseudo bobbing, it always this may not be there. Always only will be fast component, just like the second case which I showed. Sometimes it's only fast component, sometimes rapid down and slow upward. Your question is how to differentiate from a downbeat nystagmus. Am I correct?
Yes, sir. Yes, sir.
Right. In downbeat nystagmus, always the pathology is a slow component. The first thing is the slow component upward and fast component downward. That is a downbeat nystagmus, and it is purely vertical. Here it is vertical and converging inside. And the frequency varies with time. Sometimes it may be fast, sometimes it may be slow. That thing will not occur with the downbeat nystagmus. And usually downbeat nystagmus is classically worsened by looking down and out, so-called side pocket nystagmus.
Okay, sir. Okay, sir.
And moreover, ocular bobbing is usually seen in pontine lesion in a comatose patient.
Usually we say ocular bobbing, dipping, they don't have any localizing values, right? It is can be anywhere in the brain.
Yeah, what you said is correct. The ocular bobbing has got a localizing value because it is usually indicated pontine hemorrhage, but has been described with extrapontine compression also. Even in metabolic encephalopathy, also rarely described, but most commonly it's a insult to the pontine, acute insult to the pons. On the other hand, reverse ocular bobbing, ocular dipping, reverse ocular dipping have no good localizing value. Their out can be seen with toxic and metabolic encephalopathies. Hypoxic encephalopathy can produce the other types.
So how will you differentiate between downbeat in nystagmus and ocular bobbing other than the altered sensoria?
Yeah, that's what I just now told you. I'll tell you once again. Always nystagmus should have a slow component. Okay. Here in ocular bobbing, the fast component is the pathological component, the first downward movement and a slow return. Whereas in the case of a downbeat nystagmus, the slow component is upward, that's the first thing to occur, and the fast component is downward. This is the onset of the nystagmus is important. Second point is that it is in the case of ocular bobbing, it is it can occur at any time. Then irrespective of your eye position. In downbeat nystagmus, it's almost always worse on looking down and out. That is another point in ocular bobbing. Otherwise, it can, and second is the comatose state. It can mimic a downbeat nystagmus. In ocular bobbing, it comes down and remains for some time slowly go upward. Not like a nystagmus. Whereas nystagmus, goes up, down like that. In ocular bobbing, I'll show the video. I think I can, next time I'll show the video of classical ocular bobbing and a downbeat nystagmus to differentiate. Now I cannot incorporate now. I'll show it next class.
Okay, sir.
Okay. Differentiate between ocular bobbing and downbeat nystagmus. Okay, shall I go to the next case?
Yes, sir.
Okay. Now, this is again another case by Dr. Samia. This is a very short case. 7-year-old boy who had a history of neonatal hypoglycemia with symptomatic seizures. He was on levetiracetam and clobazam since birth. Later, clobazam was stopped and he was on subtherapeutic dose of levetiracetam. However, even with that dose, he was doing very well without any seizure. Her mother has brought him for a second opinion after she has seen an ophthalmologist for the child's headache and constant rubbing of her left eye while trying to read for the last 2 years. So, in fact, she has come not for the seizure or anything, only for this headache, and on the advice of an ophthalmologist. He was also under treatment for vernal keratoconjunctivitis for the last 2 years by the same consultant neurologist. So this is the video of the patient.
তাকা এদিকে তাকা
You can the left side.
তাকে তাকা এদিকে তাকা তাকা পুরো
Nystagmus, no, ocular movements
এদিকে
separate
তাকা
normal.
তাকা আর টুকা তাকিয়ে থাক এই আঙুলটার দিকে তাকা তাকিয়ে থাক এই আঙুলটার দিকে তাকা তাকিয়ে থাক এই যে এই তাকা তো ওপরে নিচে নিচে তাকা আচ্ছা ক্যামেরাটার দিকে তাকিয়ে থাক
Now look when he closes right eye, left there is a nystagmus.
ক্যামেরাটার দিকে
First
তাকিয়ে থাক
component to the open eye, to the left side.
তাকা ক্যামেরার দিকে
Left eye, there is again
ক্যামেরার দিকে
nystagmus, but
তাকিয়ে
less
থাক
prominent than on the left eye.
এবার ক্যামেরাটার দিকে তাকা 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 ক্যামেরার দিকে তাকা আচ্ছা আচ্ছা এবার এই আঙুলটার দিকে তাকা এই দিকে তাকা তাকা তাকা
Okay, I'll show a slow motion video. Same child. The important matter I will show. Close the right eye. You send nystagmus appearing with fast component towards left side. When both eyes open, there is no nystagmus. Close the left eye, there is similar nystagmus on the right eye, but much less compared to that of the left. So what do you think about this condition?
Congenital manifest latent nystagmus.
Manifest, what is called? What do you call it?
Congenital manifest latent nystagmus.
No, it's not latent nystagmus. What he said is correct, latent nystagmus. Actually, it has no problem at all. The only complaint, see, usually what is the complaint of the diplopia? They'll complain of blurring of vision when you use with both eye, and they are fine after closing either eye. They are comfortable because there is no diplopia, no blurring of vision. Just to opposite that, you want to latent nystagmus. With both eyes, they are comfortable, but with each eye closing, their vision become blurred. See, each eye closing vision is blurred, but both eyes, they are better. Just to opposite of that diplopia complaint. So as told, as the doctor has told, this is called latent nystagmus. It can be bilateral, it can be only confined to one eye, it can be asymmetrical also. This is another pair. There's no problem in closing the right eye. There's no left eye. Okay. But closing the left eye, there is nystagmus in the right eye. It's called latent nystagmus. Focus on this eye, right eye. Okay? This is another one from literature. This is not my patient. It can sometimes occur on both sides. So this is nothing to do with the patient's history. This is latent nystagmus. Okay, any questions?
What was the vision, sir?
Pardon?
Vision?
Vision acuity is normal if they view with both eye. If you close one eye, the eye with nystagmus should show blurring of vision. It's not because of the visual acuity loss, it is because of the nystagmus causing the blurring. If it is a mild nystagmus, they won't have any problem at all. Visual acuity will not deteriorate. Just the person I showed you had no complaint. Instantly he picked up.
Okay, sir.
Okay, shall I go to the
Cause for
log?
this, sir?
This is a congenital problem. I do not know the exact mechanism of latent nystagmus. It's one type of a congenital problem. I had to look up the what's the explanation. I do not know. I had to look up a little. Okay, shall I go to the proper case? This is a story of a 3-year-old boy. Because I wanted to show this case today because Abdul Rahman wanted, I wanted to see this case, which I presented much long ago in this forum. He was apparently all right till 5 days back when he started complaining of pain in the limbs and disinclination to walk. Next day, he was crying most of the time and was not walking at all. No history of any preceding fever or diarrhea. This is the child. He cannot hold the limb right? It's weak, all the four limb. It's got a severe pain also. He cannot flex the leg by one his own. Whether you have pain or not, we do not know, but he's not able to stand at all. The reflexes were all absent. Reflexes were all absent. Pending sign was positive. And next division is also positive. But it's a pain coming on pressing the neck. So on examination, kindness were grossly normal. What examination was difficult in view of the fact that the patient was resisting any kind of movement due to pain. However, there was weakness of both upper and lower limb. Could not get up from bed or stand. DTR all absent. Neck stiffness positive. That's mild neck stiffness, but SLR and connects were strongly positive. So, what do you think the child might have been having?
It's a painful GBS.
Very good, painful GBS because got a reflex. Weak. Yeah, right. GBS can have also positive Kernig sign. Neck stiffness is less common, but one is very common because of the inflamed nerve roots. Okay. So this is the test done, the non-cell count. So what test you need now?
Conduction.
The conduction was done, and CPK because of the severe pain, I also did a CPK because we do not know whether the absent reflex was due to the uncooperation on the child. So this is the CPK. CPK was normal. Okay. Then proceeded with the nerve conduction. This is nerve conduction. Left peroneal and right peroneal latency very much prolonged. Amplitude is low, and look at the velocity is also very much decreased. Then right T also the same thing. Right tibial and left tibial also the amplitude is low, but the latency is relatively okay, but mild decrease in the amplitude. Left medial latency is very much prolonged. And see the conduction velocity, all are decreased in the range of 21, 22, 27, etc. Grossly abnormal. Come to the right median again, same. Left ulnar, both ulnar, the distillate is prolonged. Conduction velocity is prolonged. And sensory potential all absent. FA is present only in right tibial and left ulnar. Another nerve it was prolonged or absent. So what is the diagnosis now? GBS. Okay, demyelinating polyneuropathy. Nothing I can say GBS. So what do you want to do now? Anything else you want?
Nodopathy panel, sir.
No, this is why this is only classical case of GBS.
Oh.
So do you do nodopathy investigation for all patients? We don't do.
Yes, sir.
The painful GB can have NF155 positive. So
Yeah, but so there's no meaning in exam doing investigation like that. You know, any GBS can have pain. We don't usually send for nodopathy and neuropathy antibody for these patients. It's a garden variety. We say send the patient for this. Okay, you can see.
CSF study, sir.
But my question is, why do you want CSF study for?
MCS shows a clear GBS, so MCS as
It's
a
a clear.
study.
Yeah, may not be required, no. Because I don't need, because this diagnosis is certain. So gross demyelinating finding the nerve conduction. And it's got absent reflexes, preceding fever is there. So classical GBS. So what treatment will you give? IVAG, correct? Okay.
Yes, sir. Correct.
So still he
But,
had nystagmus, sir.
yeah, that's the point I want to tell you. In GBS and all, you can have nerve root inflammation and if you, the so-called painful GBS, if you elevate the leg, they can have pain. Suppose cervical roots are affected, they bend the neck, they can have a pain, just like a meningitis.
So we have to find out the etiology like Lyme's or TB. So anyway, CSF.
That too, that part I'll agree with you. But in those situations, you won't get a prolonged distal latency and prolonged conduction velocity like this. That indicate the problem is not only in the root, but also in the periphery. It is there in the periphery. See, if you've got a radiculopathy due to Lyme's disease, that's very rare only, lymphoma and all, root can be inflamed due to the meningeal pathology. A meningeal pathology affecting the roots will not produce a prolonged distal latency or a prolonged conduction velocity. That indicate that the myelin is lost in the peripheral part of the nervous system. If it is not, then only a latency is prolonged, you've got a point. There you have to think of other suppose distal latency is normal, conduction velocity is normal, telling you that the peripheral nervous system part is not affected, but only FA latency is prolonged, indicating that can prolong in root lesion also. There it is justified to do the CSF at this point of time.
Okay, sir.
So I put on IVAG, but there was only very mild improvement, and child continued to scream because of the pain. This is even after 5 days of IVAG. Not was lying down because of the pain. The reflexes continued to remain absent. He is not able to stand or sit. So what do you want to do now?
Give steroids and
Steroids.
Do you give steroid in GBS?
Wait for a week.
Well, it's certainly contraindicated, no?
Wait for a week.
Wait for a week, okay. So, since there is name, CSF was done. CSF showed a protein of 383, glucose 68, cell count 2. Gram stain was negative, no organism seen. And this is a protein 383, glucose 68, cell count 2. Now, what do you want to do now? Protein is elevated, but no other evidence of inflammation like an elevated pleocytosis.
Wait for a week, sir.
Wait for
Rule
a
out
week.
arachnoiditis, MRI spine with contrast.
Yeah, they can do that, but even then I'll tell you arthritis, so you can do that. But even if there is enhancement to the meninges or roots, it indicate only part of the G base only. Because arthritis cannot explain the peripheral nervous system damage. That's the point I already told. The lesion has to be in the peripheral nerves. Plus, roots may or may not be affected. To find that root involvement, you can do the contrast, etc. Okay. And MRI, you wanted MRI. Why do you want MRI? CSF protein is the only point I thought slightly higher than that of AADP, but that's not totally against. I skip that particular side. So MRI was done. See what did it show the MRI? This is the pre-contrast. This is the contrast. You can see the enhancement of the cardiac and nerve roots. Sorry. This is the left is enhancing. Cardiac and roots are enhancing. This is the before contrast. This is after contrast. You can definitely make out the difference between the two. This is the axial cut. You can see the cardiac and roots. You can enhancement. That's enhancing cardiac and root. See the roots enhancing there. Contrast. Compare the difference between the two. You can clearly make out the enhancement of the root and the associated meninges surrounding that. You can see that root. This is the thoracic spell cord also. There was enhancement surrounding the meninges. Brain was done. This is a brain T2 weighted sequence. Nothing abnormal. This is the flare. This is the, look at the contrast now. You can see the fifth nerve as well as the seventh and third nerve getting enhanced. We will come down. Just wait for some more time. You can see the nerve enhancing. That is a pons. And see, that's the fifth cranial nerve it getting enhanced. And this is the seventh which is getting enhanced on the left side. And respond. I'll show the freeze frame later on. This is the fifth cranial nerve. This is the seventh cranial nerve. And taking it up, you can find even enhancement of the optic chiasm little bit. See the optic chiasm is also lately enhancing.
TB, sir.
Pardon?
TB, sir.
No tuberculous. I'll come to that. CSF is already no cells in the CSF. Nerve alone is getting enhanced, not the meninges. This is the coronal cut. Nivelle show the static. This is the enhancing fifth nerve on both sides. And that is the seventh nerve enhancement on the left side. And there is also some degree of enhancement of the optic chiasm. Fifth, seventh, third cranial nerves as well as optic chiasm. So what will you do now?
NMMOC.
Steroids.
No, it's clearly a peripheral nervous system demyelination. There may be an associated cranial nerve enhancement may be there. Someday we can think a combined central peripheral nervous system demyelination, but that parenchymal lesion is not there. Only the peripheral nervous system per se, except for the optic nerve, some enhancement. Only they all were confined to the peripheral nerves.
Plasmapheresis, sir.
Okay, let's see. Next day, some treatment was given. Next day, the pain decreased by about 80%. Next 2 days, pain totally gone and showed significant improvement in the power. This is after that treatment. Now the reflexes started appearing. Reflexes started appearing. Still otherwise comfortable. She stopped crying. Lower limb reflex angle appeared, but knee did not appear. So repeat conduction was done. Same finding. It's got profound demyelination picture still persisting. The amplitude become a little more lower, but clinically child is become much better now. Again, sensory conduction not potentially picked up. So this at the time of discharge, this is the patient. Still, she can make out the weakness in the proximal muscles now. She's tendency to buckle, bilateral foot drop. Now, after 2 months, this is child after 2 months. Then he ejects his come back. And we check his also come back. This is again 1 month later. She improved totally. What is the treatment I gave?
Observation, sir.
The pain on the next day.
Steroids.
Very good. See, somebody initially steroid. See, I am not against this is a personal opinion against giving IV. I have seen many patients who have got a painful GP improving remarkably with IVM. This child was IV methylprednisolone, the milligram per kg according to the pediatrician decided. This is what I have done, nothing else. Why I brought the case was I went to the neuro update last week. There the person from USA was telling about this is contraindicated, things like that. And so many people in North India, as well as myself too, that's not like that. Even before these, so those people who could not afford plasmapheresis or IV, what are you going to do? I've seen many of them improving with IV methylprednisolone. So I think this old textbook version or sometimes may not be true. See this side. I can guarantee that next day after starting the IVMB, her pain subsided. It cannot be natural course. And that IVMB given for, IVAG given for 1 week, given, and I waited for 1 week for the improvement to come. Still there was no improvement. So that is why I brought this case to enlighten this particular point.
So in patients with painful GBS, usually with plasma exchange, the pain comes down better than IVIG.
Maybe, that may be correct. Yeah,
We have seen.
Okay, that's also maybe right, but because this being a child, I preferred IVAG because cost will be less.
In GBS, that's in contrast enhancement of the roots. No?
Yes,
Sir,
yes.
how much is sensitive that because in the first week the NCS and the CSF may be normal. So for a diagnostic purpose, can we use it as a diagnostic marker?
Which one?
Contrast enhancement of the roots, lumbar.
No. You cannot use it at all. Usually contrast enhancement is in CADPs, but GPs also can produce this contrast enhancement. So you cannot. You cannot. It may be there. It may not be there. That is not the criteria. Here, why we are strong about deep peripheral amylase? No context. That is undoubted about it. It's not a borderline decrease in the velocity, gross decrease in the velocity. Then lesion is in the peripheral nervous system. If we have root enhancement, that means root is also affected. That does not tell there is a confined only to the root. Now, this is from the literature. It is essential that contact administered diagnosis suspected as non-important. Typical findings in GPS are surface thickening and contrast enhancement on the cornus medullaris and the nerve roots of the chorda equina. The most common set of enhancement in GPS is considered to be anterior nerve roots, although enhancement of the posterior roots is also seen. In the brain, facial nerve is the most commonly affected cranial nerve by enhancement. This is our patient. This again from the literature, same just like our patient. This is our patient. This is from the literature. The enhancement of the chorda equina and the cornus region. This is from the literature, just like the enhancement we had seen our patient. This is from the literature.
How long it takes to appear this enhancement? The day one itself it appears?
No. I don't know because we usually do not know contrast enhancement in GBS at all. How many times we do? We hardly ever do. It is not required also. This I did only because child did not improve with IVAG, and that is why I was thinking something else is occurring in addition, like a sarcode or something like that, which can affect both peripheral nervous system and the nerve roots. That is why I did not. And more thing, the protein was slightly more than what we normally get in GBS.
So this atypical presentation, can it be acute to CADP?
Yeah, that point cannot be totally ruled out, acute CADP. The only thing is acute CADP can diagnose only retrospectively. After, in the sense that after 2-3 episodes occur, then only you can say it was acute CADP. Otherwise, it's a GBS only.
Sir.
Yes, Parmeshwara. Yes.
Sir, truly speaking, sir, we also give, sir, after getting informed consent. Many of our patients are not at all able to afford IVAG. So after getting informed consent, we used to, because patient on stage 3 to stage 4, rapidly growing GBS, sir. They
Yeah.
are not able to afford a IVH or Plus. So we give, everybody will improve, sir.
Yeah. Hello, my question is, why do you want informed consent for? You cannot take a decision.
Suppose
You can
somebody
take-
goes to court, sir, we have to stand, sir.
No, this is
A question, somebody, after some time, everything will, they will turn the,
yeah,
their
yeah,
words.
correct.
So
It's
usually GBS is painless. So why some patients develop pain?
I
Is
do not know.
it,
Some right, what is it is some people have severe pain. They can come like a dispersal. They can SLR may be positive, severe backache and radiating pain, and SLR positive. But there the conduction gives the clue.
Maybe small fiber involvement.
Yeah, even though not common, that may be the reason. Pain fibers are also affected. That usually indicates, as you said, some root inflammation is also occurring, causing the small fiber affection. That is why the pain is occurring.
the nature of the pain is not that of a small fiber involvement. It's usually a somatic pain, like pain because movements, stretching, everything.
No. They can have something mimicking a radicular pain. They can occur. They can have backache and radiating down. They can occur. Actually, the affection of the root is causing the pain. That can occur. Usually, they do not come with a distal symmetrical type of pain. They don't come in GBS.
They can have tenderness also, or muscles of calf muscles.
Yes. Very well.
So
very well.
that could be because of the inflammation of the perineurium.
Correct. That what you said is correct. So the inflammation is not only in the root, but also the peripheral nerves also. But what I'm trying to say, it's not the pain of this is the like a diabetic small fiber neuropathy occurring distal symmetrical pain. That's not the pain they get.
CPK also has to be looked.
CPK usually not that mild elevation can occur, but not to a great extent. Here also CPK was not elevated. Okay, shall I go to the next case?
Yes, sir.
Sir.
Okay. So this is a story of a 38-year-old female. In this case, I was given by Dr. Anis from Travancore Medicity. He has history of fever 2 months back, which lasted for next 5 days. 5 days later, the patient developed vertigo associated with tinnitus of the left ear and deafness on the same side, left side. The vertigo used to increase with the change of position. Along with the vertigo, patient noticed imbalance while walking, imbalance while standing, with tendency to fall backward. That is what the patient told. The vertigo subsided with treatment 4 days' time. The tinnitus of the left ear subsided 2 weeks' time. However, since that time, the patient was complaining of imbalance while walking. So it's a fever 2 months back, which lasts for next 5 days. 5 days after the onset of the fever, patient had vertigo with tinnitus and deafness on the left side. The vertigo was more positional, and patient noticed imbalance while standing, tendency to fall backward. The vertigo and tinnitus subsided in due course, but the imbalance while walking was persisting. That is why the patient was referred to the neurology department. This is the patient. He had no nystagmus. ഇതിലോട്ട് നോക്കുമ്പോൾ നോക്കിക്കൊണ്ടേയിരിക്കണേ ഇവിടെ നോക്കുമ്പോൾ മുകളിൽ താഴെ കണ്ണ് മുറുക്കി അടയ്ക്ക് മതി കണ്ണ് തുറന്ന് നോർമൽ ആന്ന് പറ നാക്ക് നീട്ടുമ്പോൾ നാക്കങ്ങളോട് തള്ളിക്ക് ഇത് കേൾക്കാം He could hear both here normally now. Power is normal. There is no finger nose incoordination. Slowly. Elution test was negative. ഇനി അതേപോലെ മറ്റേ കാല് ചെയ്ത് കറക്റ്റ് താഴോട്ട് കൊണ്ടുപോകാം. താഴെ മുട്ടിക്ക് അതിന് താഴെ മുകളിൽ വെച്ചേ. ഒന്നുകൂടെ ചെയ്തമ്മ. The reflexes were all normally elicited. Slightly on the viscous side. Plantar was flexor. Vibration normal. Joint cells normal. Little finger also she is correctly. Lower limb also is normal. Same. Right left also is normal. It's made to get down from the bed. Balance. Rhombus has to testing the rhombus. After she could stand with the open eyes, but when closing eye after standing for some time, she tends to fall. Okay, then she is made to walk about. He walks very cautiously with broad waist gait. He walks as if walking on an ice. On turning, she had imbalance. And walking was grossly abnormal. Okay, these are the findings. So, what is the diagnosis in this patient? Findings. Vestibular neuronitis can produce such an ataxia unilaterally. No nystagmus.
Deafness was also there. So
She professionally falls to.
Pardon? She tendency to fall to either direction.
So is it a functional?
Yeah, could be functionally functional. Looks like the way she initially stood for some time, then started showing this may be functional.
So predominantly the patient has a gait ataxia, sir, rather than a appendicular ataxia.
Perfect. Your body said is absolutely correct. No lower limb ataxia, no upper limb ataxia, no nystagmus.
So it can be localized to the vermian, paravermian, anterosuperior vermis.
Yeah, if a superior vermin lesion, if it's a vermin flocranoidal lobe lesion, vermin lesion, you can like to take some eye movement abnormalities, producing truncal and gait ataxia without a limb ataxia. If the lesion was in the anterior lobe of the cerebellum, that is so-called superior vermis, you get gait ataxia plus lower limb incoordination. Eye movement may not be there. So here the patient had no lower limb incoordination. Only gait ataxia is there.
Hit was positive, sir.
Sir,
Pardon?
Hit was positive, sir.
Where do you want hit for?
Bilateral vestibulopathy.
Okay, right.
yes, sir.
Okay, MRI brain was done. That is came with MRI normal. Anything you want to do? What I said is correct. Look at the picture now. It's got a hit is positive bilaterally. You are not convinced, I will show it slow motion. Okay, then we'll make it because we'll see this one. See that. See that catch up saccade. See that very clearly seen bilateral vestibular. Now, the point I want to bring is sometimes you see the gate, it may appear functional. It looks very much like a functional gate only. But because then you look objectively, there is no nystagmus, there is no incoordination. Then you may think that patient has got functional gait because there is no sensory loss, no cerebellar involvement, nothing. And you won't get any nystagmus because nystagmus and vertigo only occurs if it's a symmetrical involvement of the labyrinth. If both labyrinth is knocked out, you will not have any vertigo. This patient had initially vertigo, so that is indicating a symmetrical involvement. When both sides are affected, the vertigo subsided. There is no nystagmus, but left with severe imbalance. So never forget to do, and they can have positive rhombogism because see that of the three inputs which maintain the balance, one is a submental input from the lower limb, labyrinthine input, and the third is the vision. When the posterior column is affected or sensitized, is there, the vision will compensate for some time. That is when you close the eye, it will burst. Same thing can also occur with the labyrinthine involvement. When both labyrinthines are knocked out, there can be compensation by vision as well as the proprioceptive. So, such a situation, when you close one eye, one more arm of helping is gone. The only thing is a proprioceptive. So, you get a positive rhombogism, even in bilateral vestibular. But more classically, that rhombogism in sensory ataxia, but bilateral vestibulopathy can also produce positive rhombogism.
Unilateral will not produce.
Unilateral will not produce any in acute vestibulopathy affecting one side. They can have a tendency to fall to one direction, the same side, the affected ear, on standing, that too with eyes closed. Most of the time, they can able to walk or without any support. Especially after 3 days, their compensation will occur, they will not have any problem. Because the balance is kept by the input from the opposite labyrinth, which is a normal labyrinth. So in acute vestibulopathy, till the opposite labyrinth takes over, there will be mild imbalance, tendency to fall in the same direction. But they can walk without any problem with open eyes.
The initial event could be, sir, vestibular neuritis, and then it progressed to vestibulopathy, bilateral.
Yeah. In this patient might, unfortunately, the usual scenario producing bilateral vestibulopathy is drug-induced. The patient must have admitted the fear, they must have received the gentamicin treatment, and following that, after substance fever, they come with imbalance while walking. But this situation is uncommon because most of the time, vestibular neuritis is unilateral. Rarely only they occur bilaterally, but this patient had unfortunately bilateral vestibular neuritis. Because the deafness party was there on one side initially, that also subsided. Now there is no deafness.
Dynamic visual acuity was abnormal for this patient.
No, that he did not do because anyway we know the birth threat is positive. Dynamic visual acuity invariably will be positive.
Okay, sir.
My last question to you, what will be the complaint of the patient? What question will you ask about the particular patient? What complaint will you ask in this particular patient? With bilateral...
Bosulopsia while walking.
Exactly. Correct. That's the answer I want. The oscillopsia means subjective evolution of movement of the object. There are two types. One oscillopsia when the patient is not moving, that can occur due to abnormal ocular movement, classically a downbeat nystagmus or acquired pendular nystagmus. They can have oscillopsia. But that oscillopsia will be present whether the patient is static or moving. Here, the oscillopsia occurs only when the patient is walking about because of the defective vestibulo-ocular reflex. Vestibular reflex is for what? To maintain the eye onto the target, irrespective of your head movement. In whichever direction your head moves, the eye will be focused exactly on the target because of your intact VOR, intact vestibular ocular reflex. When both labyrinth is knocked out, VOR is lost. Every head movement will be, there will not be with every movement, there won't be corresponding compensation eye movement is occurring. So what will happen? Along with the movement of the head, the eyes will also move upward. So the object cannot be focused onto the fovea. So you get oscillopsia. The usual story is when they walk about or travel in a bus, you can see the board on the side or the number plate, etc. will be moving up and down. That is oscillopsia. But
In
walking.
dorsal eye movements, if we examine what will be the finding in this case, dorsal eye movements.
Dorsal eye will be normal because the produce dorsal eye movement. Why do you want to do head thrust in a rapid movement, fast movement? Because for dorsal eye is taken by two things, not only by your VOR, but also by the pursuit system. When the pursuit system is also knocked out, only the dorsal eye will be affected. To find out VOR, you have to do quick movement. That is why head thrust is we are giving. See the movement which I did, not a slow movement, sudden jerk to either side. If you do a slow movement, it will be normal because the pursuit system will take over. Suppose you look at your finger and move the head, the pursuit will make the eye on the target. Whether your target is moving, your head is moving, it's essentially the same. So if it is slow, only the pursuit can operate. If you move the head to a rapid movement, the pursuit system will not work. Pursuit system will only work when the movement of the target is about 15 degrees or so. I forgot exact degree. So beyond that, you will not. So that is why you have to do a head thrust, not VOR. So if the VOR, if the pursuit system also is affected, this will be affected. So to produce loss of VOR totally, the conventional way, you should have both loss of vestibular system as well as the pursuit.
Okay, sir.
There is one condition where you do slow vision, that's called VVOR, visual vestibular ocular reflex, that is in the canvas. Canvas is a condition where the affection of vestibulopathy plus cerebellum is affected. Cerebellar ataxia with neuropathy and vestibulopathy.
Vestibular ataxia.
Vestibular ataxia, correct.
Sorry, vestibular areflexia. Areflexia or
Areflexia
ataxia?
syndrome.
Areflexia, correct. Areflexia, correct. That is both cerebellum is affected and vestibular system is affected. There we do VVOR. VVM and visually guided, visually oriented VOR. Then you look at slow movement also will be affected. Because both are knocked out.
I didn't understand that pursuit part, sir.
Pursuit path. So what is the purpose of the pursuit is what? Slow tracking of the object. That is no. Saccading is a fast movement. To slow track, suppose your finger is moving in a slow pace, okay, the eyes will gradually follow that the object. But that's a pursuit system. When you pursuit, that means pursuing that your image. The image is moving at a slow speed only, the pursuit system will operate. The image is increasing the velocity, pursuit system cannot catch up. Then you will have to, the pursuit will fall behind your movement of the target, and it will be substituted by a saccade. You get a saccadic pursuit because object is moving faster. So pursuit cannot catch up. Then you get a saccade. Then again catch up. That's called a saccadic pursuit. So here that is what in the pursuit system is operating not only when your finger is moving, but head is also moving in a slow pace. Pursuit will occur. Then only you can keep that eye on the target. You got the point. See, just it's both the same. Whether you move the target or move the head, it's a pursuit system will operate.
Yes, sir.
But it should be in a slow pace only. Fast movement, pursuit cannot operate. Just like fast movement of the finger, fast movement of the head, the pursuit cannot operate.
Okay, sir.
Is it clear to you now?
Yes, sir.
Okay.
Yes, sir.
That's what I said. To result in loss of the conventional VOR, you should have impaired pursuit system as well as impaired vestibular clarity. Okay. So shall we close today? Any other questions?
The treatment for this patient.
That's the most difficult part. Nothing can be done. Only thing is vestibular training. So what I have to do, ask them to do is that you have to train your other system to compensate. So luckily, if it's since it's a vestibular neuritis, there's a good chance for improvement, spontaneous improvement can occur. Patients already given steroid, they're likely to improve because it's a vestibular neuritis, just like any other neuritis. The crucial problem is not this. The drug toxicity is knocking out this thing that is irreversible. There, what you have to do is just like this patient also, you are doing gait training. So ask the patient to walk initially with a little more broad case, then gradually narrow down, and then walk a tandem walking. Then ask you to remain close to the wall and close eyes. You will fall down. Try to catch hold of the wall every time she falls. That way, you can enhance the proprioceptive mechanism and the visual mechanism to compensate for this labyrinthine deficit. As told before, there are three things which with the three inputs which make your balance proper. The visual input, the proprioceptive input from the periphery, as well as your labyrinthine. When one is lost, the other two systems you boost up. You have to get training, just like a gait training, you have training for the proprioceptive input. Then the other thing is, then you can the other thing you can do is that ask the patient to stand on a what do you call it? A soft pillow. That again will tune up your central nervous system to compensate for that. I did not hear Parameshwar, what did you say?
They used to walk fast normally, but they used to have to slow movement only very got difficulty. So walking fast also is another training too.
Walking point. The problem is their patients imbalance. They walk very cautiously only. They don't walk that. They will not walk only slowly. Just like the lady, which I saw now walking with the broad base. Actually, she's not walking because of cerebral involvement, because of the cautiousness. Because the fear of.
This type of severe attacks is mainly manifested in the slow pace. If they walk a little the fast pace, they'll become they seems to be little normal only.
I don't think so. I'm going to walking also will become more of a balance to be maintained rather than walking slow.
Can we provide some vestibular adaptation exercise?
That's exactly what I said. I was telling now. Walking on walking tandem. Initially walk with a broad case, gradually narrow the base. And also walk on a soft pillow, walk on a soft surface. Then ask the patient to remain the closed wall and keeping your eyes closed for some time. They fall. Then again, gradually increase the distance between the wall and the person. Like that, you can give some vestibular adaptive exercises. The idea is to fine-tune the other compensatory mechanisms which maintain the balance.
Acyclovir is usually given in the initial phase or polysteroid.
Initially steroid with acyclovir or valcyclovir. Because presuming that it is a viral infection, we do not know actually which virus is causing. Okay, then shall we close?
Thank you, sir.
Thank you. Okay. Thank you, sir.
Please.
Thank you, sir. Thank you, sir.
Okay, thank you.
Sir,
Thank you.
for the
Good night.
painful GBS patient,
Painful GBS, yeah.
that patient,
Yeah.
snaps are all absent. Is that
Snapper
any-
all absent.
All absent, no? Usually the sural may be spared, no, in usual
Yeah.
GBS.
Yeah, correct. That Well, that only indicates the severity of the involvement. That this why the other things are all applicable. Early GBS, you can get this kind of a phenomenon. Otherwise, that can be involved. See, GBS, depending upon there are various types, motor GBS, motor sensory, some of them might be predominantly only sensory. So various types. The classical GBS sensory is less affected, but some of the GBS kind of sensory also dominantly affected.
Okay. Thank you, sir.
Thank you. Thank you.
Thank you, sir. Good night. Good night.
Thank you. Good night. Good night.
Thank you, sir. Good night. Good night.
Good night.
Good night.
Good night.
Thank you, sir.
Thank you. Thank you. Next week, we'll meet next week.